Thank you so much, Ahmed and Elia, for the lovely introduction. Now I move on towards my panel. It is an honor for me to host such an experienced panel. The topic of discussion of this panel is demystifying ADHD, that is Attention Deficit Hyperactivity Disorder and Autism Spectrum Disorder. We've heard these statements many times. People with ADHD can never focus. People with autism cannot form relationships. ADHD is a result of bad parenting. These are some of the misconceptions associated with ADHD and autism. The aim of our panel discussion today is to demystify such misconceptions and to educate masses regarding the symptoms, treatment, procedure, and management of these disorders. For this, I would like to welcome our very first panelist, Dr. Joan Flood. Dr. Flood is a physician in Toronto, Canada, and her practice is specialized in management and assessment of children, youth, and adults with ADHD, autism, depression, and anxiety. She's also a board member of CADRA, the Canadian ADHD Resource Alliance. Welcome, Dr. Flood. I would like to ask you, what is attention deficit hyperactivity disorder and what are its causes? Also, if you could tell me the scientifically supported guidelines for diagnosing it.
So what is ADHD? Well, ADHD is a neurobiological disorder. It is the most common disorder seen in a child psychiatrist's office, as well as a prominent disorder in adulthood. Many of your patients who suffer from depression and anxiety in adulthood probably have underlying ADHD. It is not well recognized in adulthood, yet it very much is there. Estimates of ADHD prevalence are 5 to 9% in children and 4 to 6% in adults. Children with ADHD more often than not have persistence of ADHD symptoms in adult years. So this is not just a disorder of children. This is a disorder that affects individuals throughout the lifespan. It is extremely impairing, but it also is easily treated and managed so that individuals can have a much more successful outcome. It is a common misconception that ADHD is not a real disorder, or that it's an excuse for bad behavior, or that it's something that pharma has invented to sell more drugs. This is not the case at all. These ideas are often fanned by the media, but this does not reflect ADHD. ADHD is a neurobiological disorder with definite causation and definite signs and symptoms that are impairing. So what causes ADHD? Well, multiple genetic and environmental factors contribute to the causation of ADHD. Without a doubt, genetics is the most significant factor in the causation of ADHD. We know from multiple studies that this is a polygenic disorder. Many genetic variants, each having a small effect, combine to increase the risk of ADHD in individuals. A parent with ADHD has a greater than 50% risk of having a child with ADHD. And in fact, we know that the heritability of ADHD is as common as the heritability of height. So this is very often a familial disorder. Environmental factors can also contribute to ADHD. One common environmental factor in the perinatal period is maternal smoking. Over and above the genetic effect, maternal smoking can increase the risk for ADHD in the unborn child. Exposure to alcohol in pregnancy, as we know, can cause alcohol-related neurological defects or fetal alcohol spectrum disorder. And these children too have symptomatology that is akin to ADHD. In terms of dietary causations, we do know that in parts of the world where there is heavy lead exposure, children with high lead levels will have up to a 2 to 4 times increased risk of ADHD. Dietary factors causing ADHD are not prominent, but we do know that iron deficiency, vitamin D deficiency, and a diet that is inadequate in omega-3 fatty acids can increase ADHD symptomatology. I certainly wouldn't want to leave you with the idea, though, that diet is the cause or cure for ADHD. It is more complex than that. We also know that there is a stepwise increase in the likelihood of ADHD in children born prematurely. A child born at 28 weeks gestation is much more likely to have ADHD, even if there is no underlying genetic factor. These children probably experience intracerebral trauma in those early weeks of life that contribute to the causation of ADHD. One thing that has recently been recognized is adverse childhood experiences. Children who experience deprivation, neglect, abuse, live in low socioeconomic circumstances, or have been exposed to domestic or systemic violence have been shown to have increased risk, increased manifestation of ADHD. So what else do we see? We know these things cause ADHD. What do we see in the brain? Well, if you ask a psychologist, when they assess individuals with ADHD, they will see a wide variety of IQ results. IQ is not a determinant of ADHD. Many extremely intelligent people have ADHD. One will see changes in working memory, processing speed, and decreased response inhibition in psychological testing. What about neuroimaging? Well, neuroimaging is not something that we can send individuals for to diagnose ADHD, but we do know from large studies that have compared the neuroimaging of ADHD individuals with non-ADHD individuals that there are a number of differences noted in the brain. We know that there's decreased cortical surface in the brain of children with ADHD. And when one looks at the frontal and temporal cortices, along with the cingulate cortices, the basal ganglia, the amygdala, and the hippocampus, there are smaller sizes in those areas and smaller intracranial volume in those with ADHD compared to those without ADHD. So for those naysayers who say that ADHD is not real, that's not what the science shows. ADHD is real. It is a neurobiological disorder, and it is manageable and treatable. So, how do we diagnose ADHD? Well, the diagnosis of ADHD rests on the interview of the patient by a qualified clinician documenting the criteria for ADHD. There are well-defined criteria for ADHD that professionals agree upon that validate the presence of ADHD. The DSM-5 indicate that individuals with ADHD must have developmentally inappropriate levels of inattention plus hyperactivity, impulsivity in some cases. Inattention is the main criteria. This must be present in different settings and cause impairments in functioning. Typically, these impairments need to be present before the age of 12, but when one is looking at an adult with ADHD, they may not actually remember what went on prior to those years. And if one can't get ancillary information or copies of report cards from early years, one may have to go on the symptoms that exist at present. What exactly does inattention cause? It causes academic impairment. It causes failure in occupational settings. These decrease the self-esteem of individuals with ADHD. Inattention causes poor adaptive functioning and generally a negative outcome in many different areas for the individual with ADHD. For those who have hyperactivity, impulsivity along with inattention, this can be very annoying to those around them. In childhood, it causes considerable peer rejection. Similarly, in adult years, hyperactivity, impulsivity is associated with more aggression, risk-taking behavior, and accidents. ADHD also co-occurs with a number of other psychiatric disorders. It is very common for individuals with ADHD to experience depression and anxiety. For the hyperactive impulsive type and inattentive type, oppositional defiant disorder and conduct disorder can be present. Individuals who have bipolar disorder often have ADHD, as do people with personality disorders. And in those who have autistic spectrum disorder, estimates are that 30 to 70% of individuals with autism also have comorbid ADHD. Rating scales are very helpful in making the diagnosis. The SNAP rating scale and the ASRS are very commonly used in Canada, plus a number of other rating scales that we do have on our CADRA website. The rating scales are helpful, but they alone don't make the diagnosis. Again, it comes back to the clinical interview, just as the clinical interview is important in the diagnosis of many other psychiatric conditions. Typically, more male children are diagnosed with ADHD than female children. Is this really true? I'm not exactly sure, but boys with ADHD tend to be more often hyperactive, impulsive, and defiant, so they are more noticed by teachers and parents than girls who tend to be somewhat more inattentive and less obvious. When you're looking at adults, the incidence of ADHD is equal in males and females.
This is such a detailed answer, Dr. Flood. Indeed, boys with ADHD are noticed more, as they tend to be more often hyperactive and impulsive than girls who tend to be somewhat more inattentive and less obvious. Moving towards my second panelist, I would like to invite Dr. Dora Vin Chang. Dr. Dora is a specialized psychiatrist currently working in the field of adult ADHD at a private practice in Netherlands and is a member of ADHD Europe. She's also the editor of DIVA Foundation, which is a diagnostic interview for the diagnosis of ADHD, available in 25 different languages. Welcome, Dr. Dora. My question from you is related to adult ADHD. Could you please tell us some signs and symptoms of adult ADHD and how it can be diagnosed?
So let me start by saying that it's only quite recently, in fact, that clinicians were aware that ADHD existed in adults, because it was believed to be a disorder of childhood only, and that kids grew out of their ADHD. We now know that it is a disorder that remains lifelong for many people, for about 60% of children who are diagnosed. It may change as children become adolescents and then become adults, and it extends, in fact, into old age. And the unit that I work in The Hague with Sandra Coy has been pivotal in describing ADHD in the elderly. But to get back to our first question, how does ADHD present in adulthood? Well, classically, there should be a history of difficulty during childhood. In order to make the diagnosis in adulthood, one needs to have had at least 3 symptoms that began in childhood. Before the age of 12, they might have disappeared with time and evolved to become other symptoms, but there's quite a lot of debate in the literature about ADHD manifesting for the first time in adulthood. So that is still controversial, and according to the Diagnostic and Statistical Manual, DSM-5, one does need some evidence of neurodevelopmental disorder. So it needs to have had at least 3 symptoms, either of inattention or of hyperactivity, before the age of 12, that lasted for at least 6 months. The kind of adults we see are often people who have themselves children with ADHD and who recognize these symptoms in themselves. They might also be adults who have read about it or heard about it through the media and diagnose themselves. And sometimes they're people who present to a psychologist or a psychiatrist or a general practitioner with symptoms, and it is then diagnosed by the clinician. They themselves are unaware that they might have it. So similarly to children, there are 2 main groups of symptoms. The first one is inattention, struggling to pay attention, to focus, to concentrate. And the second cluster of symptoms would be the impulsivity and hyperactivity. So let's start with the inattention. Well, those are things like struggling to pay attention to detail, imprecise work, making many mistakes, getting overwhelmed by detail. Another one would be struggling to keep sustained focus, especially in tasks that require prolonged concentration or are boring, classically for adults, administration, for some people, reading, conversations, also easily distracted by internal distraction, i.e. one's own thoughts. Another manifestation of inattention would be giving the impression that you're not listening when someone is speaking to you directly. Similarly to childhood, but for example, being very dreamy, struggling to keep focus during a conversation, after a conversation having no recall of what was said, changing the topic very often. A fourth one would be struggling to fulfill tasks on time. So taking much longer than it should to complete something, starting something, but really struggling to complete it because of a lack of concentration. And for example, not being able to read through a boring instruction manual. Organization is another one. It's another one that reflects difficulty with concentration. So difficulty planning, following an agenda, being on time, keeping papers in order, arriving late. So time management is classic. Difficulty with time management. We sometimes see people who overcompensate, so they know that they have difficulty with planning, and as a result they will then spend even longer structuring themselves and being extremely rigid, and a sort of perfectionism creeps in, so they become perfectionistic, somewhat obsessive. They cannot handle it unless they strictly follow their own routine. So what are three more symptoms of inattention? Avoiding tasks that require prolonged concentration, like administration, so avoiding, procrastinating, delaying, losing objects that are important, like keys or possessions, or putting papers or files in the wrong place, being easily distracted by sensory stimuli like noise or other people's conversations, or I've mentioned already, one's own thoughts. And then also just being forgetful, like not remembering to arrive at an appointment, running home to check whether one has one's keys. Again, sometimes using lists and an agenda in a very rigid way to compensate. So those are the inattentive symptoms. We then come to hyperactive or impulsivity. Now, hyperactivity in adulthood is quite different from that in childhood. It's not the same kind of classic physical and motor hyperactivity. It's much more of an internal restlessness. And this is where a lot of people do not understand how ADHD can be diagnosed with the H in adulthood if there's no overt hyperactivity. But what we see is that instead of running all over the place and swinging from the chandeliers, adults with ADHD struggle to stay seated. They might wriggle and fidget and shake their legs. They cannot stay seated, for example, during a lecture. They make up excuses to leave their seat, or they choose jobs where they need to be very active. They are very internally aware of a sense of restlessness, so they just feel that they have to move from task to task and they cannot relax. That's another important symptom, inability to switch off and to relax. They will not be able to sort of calm down and in a quiet activity listen and be quiet. They will just carry on talking. They'll be very loud perhaps. So being quiet and restful does not come easily to them. They might also have a sense of having a sort of internal motor, so they're always thinking ahead what they need to do. They've got enormous energy. They might want to compensate by doing a lot of sport. They might even sustain injuries as a result of too much sport. Then they might be excessively talkative, so the hyperactivity comes out as a sort of verbal diarrhea. They talk loudly, they can't stop talking, they interrupt commonly. They might be impulsive. Now we've got some symptoms for impulsivity. 3, those are blurting out an answer, being tactless, not thinking ahead, struggling to wait for one's turn, battling in queues, and finally interrupting others a lot, and people notice that the person is intrusive. So those are basically the symptoms of ADHD in adulthood. We also need to have some areas of difficulty functioning. So it could be at work, education, in relationships, social contacts, hobbies, and also it affects one's self-image, actually, because by the time you've reached adulthood, you've had a lifelong history of these problems. So it's something that, that lives with you and can erode your self-esteem, and therefore may well be coupled with diminished self-esteem and difficulty with feeling good about yourself, potentially even depression. Now, we know that ADHD is highly comorbid.
Thank you, Dr. Dora. You've explained it so well and in detail. Let's discuss Autism Spectrum Disorder now. For that, I would like to invite my next panelist, Ms. Maha Ahmed. Ms. Maha has done her Master's in Applied Disability Studies. She's also a board-certified behavior analyst practicing in Canada. Welcome, Ms. Maha. Could you please give us some insight on autism spectrum disorder and tell us about some of its signs and symptoms?
What comes to your mind when you think of autism spectrum disorder? Some common responses that we receive include that they are aggressive individuals, they can be nonverbal, and they can be very socially awkward. And you may be surprised to know that this is not the case for all individuals with autism. Individuals with autism can be incredibly creative, they have a phenomenal long-term memory, and they are actually at par or even have a higher IQ than their same-aged peers. It's very interesting to me that we often speak about autism in terms of deficits or skills an individual is lacking, and there seems to be a sense of urgency to fix the individual. Sometimes it can be helpful to speak about, those problems, those concerns, so that we as professionals, parents and friends can be of support to them. However, often this is done in a way that doesn't include them, which can be very demoralizing for them. And it's very important that we include them in their own care. According to DSM-5, autism spectrum disorder refers to a broad range of conditions characterized by challenges in 3 core areas, including social interaction, communication, and restricted and repetitive behaviors. The pandemic has made us realize that social interaction is very important for our well-being, and everyone deserves to experience that human connection. However, for most individuals with autism, social interaction requires more effort. We know that individuals with autism have difficulties engaging in a wide range of social skills, which can be more abstract, such as social reciprocity or theory of mind, or more fundamental, such as making eye contact and responding to facial expressions. Communication may also be impacted in individuals with autism, which makes it very difficult for them to express themselves and for other people to understand them. Think of your own experiences when you don't feel heard or understood. How do you feel? A lot of people will say that they are angry, frustrated, and experience a wide range of negative emotions, right? And we have the language to communicate. How we manifest these feelings can look like different things for different people. For some people, their way to communicate might be aggression because it has worked for them in the past. And if we think about these types of behaviors as a form of communication, it's easier for us to empathize with them and help them change as well. We also see stereotypical behaviors, which are an area of concern for a lot of caregivers because of the social stigma attached to them. Examples of stereotypical behaviors include repetitive behaviors like hand flapping, rocking, or repeating what other people are saying, also known as echolalia. These behaviors might be a way to self-soothe or express an emotion like happiness or anxiety. And often our reaction to these behaviors is to stop them. But we should consider this a bit more. Individuals with autism can be taught when it is appropriate to engage in these types of behaviors. And our goal as practitioners should be to create an environment where they are allowed to be themselves. People with autism can also have medical issues, seizures, sleep disorders, and mental health challenges like depression and anxiety at an increased rate. It's important to note that not everyone who has autism has an intellectual disability. Thousands of studies have shown that autism is not caused by childhood vaccinations. Autism develops through a combination of genetic and environmental factors. Individuals who carry a certain gene or birth complications or older parent age are all factors that contribute to the increased risk of developing autism. We typically see the signs of autism by the age of 2 or 3, and signs to look out in the first 2 years of a child's life include no to minimal eye contact, very few engaging expressions, little or no imitation of sounds and facial expressions, little to no hand gestures, so pointing and waving their hands, minimal to no response to name, and very few or no words. Other general signs of autism to look out for include difficulties in perspective taking, so understanding how other people are feeling, insistence on routines and sameness, so for example wearing the same clothes every day, eating the same food every day. Symptoms and signs of autism can interfere with daily living, and that is why early intervention is crucial in supporting a healthy development into adulthood.
Thank you for such an elaborated answer. I'm sure it is helpful for our audience. Now we have Dr. David Wong as our next panelist. Dr. Wong is a board member of CADRA, the Canadian ADHD Resource Alliance. He was consulting pediatrician for over 35 years and had seen several children and youth with ADHD. Welcome, Dr. Wong. My question to you is, what are the comorbidities that occur with ADHD for both children and adults?
ADHD is often come together with a few other psychiatric or mental health conditions. Some of these are genetic, and some of these are the consequence of ADHD. Now, the most common ones probably would be anxiety and depression. As you have heard me talk about the untreated ADHD, many of these people, including even young children and oftentimes adults, would recognize that they forgot about doing things, because forgetting is one of the common things that happen with ADHD. And when they forget, when they go to bed, they may start to think about what has happened and what they may have forgotten. And oftentimes, this increases their anxiety. As I see adults with ADHD, they often tell me that they start worrying excessively as they become teenagers because they have procrastinated and didn't do, for example, their schoolwork or their projects. This kind of worry gradually weigh on them over time, and as they get older, they will show up with anxiety, and oftentimes anxiety leads to depression. Whether the anxiety is because of ADHD or because of coexisting anxiety that these people have, it is difficult to dissect, to tease it out, to say, is it just because of ADHD, consequence of ADHD, or they truly have a separate anxiety condition, is difficult. And the only way to tell sometimes is to find out, because some of them have anxiety even as 4 or 5 years old, with separation anxiety from their parents, when their parents have to drop them off with, for example, daycare or kindergarten at a very young age. And before they even start to show up much of symptoms of ADHD, those I would likely think that they have coexisting anxiety as a comorbidity. But it is really difficult to tell, and sometimes one have to treat the ADHD and then see how much of anxiety is still present. But it is actually not infrequent for both of them to coexist together. That is why many times when we treat ADHD, we get the ADHD symptoms much better. That means their focus much better, organization, motivation much better. They can do their work much better, but they still have significant anxiety that we sometimes have to treat or have to have counseling sessions to help them to deal with this anxiety. And anxiety and depression often coexist together. But other comorbidities can include obsessive compulsive behavior. People can be quite obsessed with some of the things in their mind that they cannot just let go, and sometimes have rituals that come together with it. They also can have Tourette's syndrome. They have motor tics as well as sometimes even vocal tics that can be existing together. And I have to mention here also that ADHD coexists with others with Autism Spectrum Disorder. It is felt that a portion of people with ADHD also have autistic features, and very often those who were diagnosed with Autism Spectrum Disorder would have ADHD also. So these are some of the comorbid conditions. Rather uncommon comorbid conditions would be mood disorder, and sometimes they even have bipolar disorder that can show up together with ADHD. I hope this answered the question.
Yes, sir, that was very informative. Thank you. Next, I would like to introduce Dr. Vamik Ali. He's a co-founder and director at Synapse, Pakistan. Dr. Vamik is a trained child and adolescent psychiatrist with a passionate interest in childhood developmental disorders. Welcome, Dr. Vamik. So I began the panel discussion with some misconceptions associated with ADHD and autism. I would like to know regarding the misconceptions that you've come across in your daily practice.
Thank you for asking this question. This is a very important question. I'll brief about, because there are a lot of myths. I might not be able, with the constraint in time, I might not be able to answer all the myths here. But there are certain important myths that I want to discuss here. The first is that that it is not a medical condition, and parents usually have this belief that it's not, all kids are hyperactive and inattentive, and we're just saying that, right, and kind of labeling the child. So that's one of the major myths that we see, which is not true, because ADHD is a diagnosis. It's a medical condition. It is genetic. It runs in the families. Along with this, generally what we see is that people think that children with ADHD cannot achieve their optimal, or they're not high achiever. So it's nothing to do with achievement, right? ADHD children can be high achiever, can do quite a lot of stuff in their life, be successful, in different areas, be it business, be it some certain skill-based job or other things. What we also see is that generally people think that ADHD is, these children are lazy or they're not willing to work, which is quite the contrary, I believe, because these children are basically very hardworking, but it's just that their mind works a little differently. It gets very difficult for them to abide by certain rules that our education system has. So that's also another concern that we see, especially when we talk about Pakistani context. What we see here is that parents come with a lot of guilt. They think that ADHD is due to bad parenting, which is completely incorrect. So parenting has its role, right, but it is not caused by bad parenting. There is a very clear role of stress. During pregnancy, if the mother has a lot of stress, that can result in a child, or put a child in a higher risk of developing ADHD. However, bad parenting is no way causes ADHD. A lot of people also think that learning disorder, ADHD is part of learning disorders. It's not a learning disorder. ADHD is a separate disorder. Children with ADHD usually do have other comorbid diseases or other psychiatric conditions. They can have learning disorders, they can have intellectual disability, but usually ADHD, if the child only has ADHD and no comorbidity, that means that that he has complete IQ, he can function normally and does not have learning disorders. Things what usually also we see in clinic is that there are also myths related to medications, that ADHD medications are used to they will impact on the child's intellectual ability, or the child somehow their neurochemicals or their brain chemicals they will be disrupted. However, this is not true. Children, if they need, like I'm not saying that every child ADHD needs medication, but certain children who require medication at optimal doses can actually function very well in the setting. If we, at many times one comes across as, every child is different, right? Every child is different, and every child has their strengths and their weaknesses. There's one more thing that I would want to say, is that a lot of time parents think that, that ADHD is only related to inattention. And by inattention, they can't give attention to anything. So if they're very focused, or they're playing game for a longer time, but when it comes to math or Urdu or English, and they can't pay attention, so they think he is just making things up. However, that's not true. Children with ADHD, if they are interested, can be hyper focused, right, and have a lot of focus and not address their surrounding because they're that focused, right? People say that children grow out of ADHD. That's also not true. It's a lifelong condition. Message for parents and other professionals would be that ADHD is a medical condition that needs full attention from not just the parents but also the teachers. It is usually it needs comprehensive management from all different professionals, healthcare professionals, and one should not worry, like the parents should not worry that taking their child to a psychiatrist or a psychologist would be something that will detrimental to their overall health. In fact, it will be a very positive change, as I said earlier as well, that children with ADHD can do and can be very, very successful in their life and in their career, but all it needs is a little bit of help to know how to deal or how to move forward.
Indeed, it's important for both parents and teachers to be trained in handling them. Thank you, Dr. Vamik. Moving back to Dr. Flood, my next question to you is how ADHD affects academic as well as executive functioning in children and adults.
So the neurobiological deficits of ADHD impairs one's executive function. So what are in fact executive functions? They are the set of cognitive processes that are necessary for cognitive control of our behavior. Selecting and monitoring behaviors that facilitate our goals, whether they are academic and occupational, or whether they are as simple as safely walking across the street or remembering what we need at the grocery store. These cognitive processes include attentional control, cognitive inhibition, inhibitory control, working memory, and cognitive flexibility. These processes enable us to plan, focus our attention, remember instructions, and juggle multiple demands, while still maintaining our self-control and emotional regulation. ADHD impacts all aspects of an individual's life. Children with ADHD have a greater risk of poor long-term outcomes as adults in almost every aspect of their life compared to their non-ADHD counterparts. And what are some of those? Well, for the individual, regardless of their accomplishments, many suffer from low self-esteem related to inconsistent performance at various times in their lifetime and the constant experience of receiving negative feedback from parents, teachers, peers, and supervisors. They often have a sense of failure related to their ADHD symptomatology. What does ADHD do to a family? Well, first of all, in ADHD families, there is seldom only one person with ADHD. If there's a child with ADHD, there's usually a parent with ADHD and maybe siblings with ADHD. So there is considerably more family discord in these families. Parents are under much greater stress raising their children, helping manage their academics, managing their behavior at school, managing their play at school. Parents have more mental health problems, often because they have the mental health problems or often because the stress as part of being in an ADHD family contributes to mental health problems, more depression, more anxiety among parents. There is far more sibling conflict when a sibling has ADHD. And in the parents, marital stress is more common. If one of the marital pair has ADHD, that is challenging. It is also very challenging for those parents to raise their ADHD children. So there's considerable discord in these families and more separation, more divorce. Academically, those with ADHD tend to struggle more. Certainly if a person is very intelligent, that can mitigate against some of the deficits caused by ADHD. But still, individuals with ADHD more often experience failure, more often drop out of school before they should, and have lower grades and lower accomplishment overall. And this very much impacts their success long-term as adults. Occupationally, individuals with ADHD often work in jobs below their intellectual ability. They often have jobs that are less interesting for them and are less remunerative. They may be less productive in the workplace, they may have higher absenteeism, and they may change jobs a lot, or they're often fired from job situations. And what does it do in terms of the healthcare system? Well, individuals with ADHD often have more accidents. They often have more emergency room visits, and there are considerably more motor vehicle accidents and deaths in those who have ADHD. Substance use disorder causes a multiplicity of problems, and it is much more prevalent in the ADHD individual than the non-ADHD individual. ADHD individuals also are not as capable as looking after themselves. They often don't look after self-care, diet, sleep, etc. Individuals with ADHD more often have diabetes, more often have cardiovascular disease, and as I've mentioned, more substance use disorder. And they don't know how best to manage themselves. In fact, an excellent article by Dr. Russell Barkley in 2018 indicated that the life expectancy of individuals with ADHD, for many reasons, is 13 years less than their non-ADHD counterparts. So ADHD is a disorder that causes multiple impairments across the lifespan. But one of the things that I really stress about ADHD is that it is manageable. And we do have good treatment for ADHD. Medications can be extremely helpful for ADHD, and we can very much change that trajectory. One of the joys of treating individuals with ADHD is that they do well, and that's what keeps me going to work day after day in treating individuals with ADHD. In closing, I can recommend a couple of resources to you. Obviously, I think our CADRA website is excellent and our guidelines are excellent, and I highly refer you there. One particular article that you may find helpful is the World Federation of ADHD's International Consensus Statement that came out in early 2021, authored chiefly by Dr. Stephen V. Ferrone, who is the president of the World Federation of ADHD. And it was contributed to by multiple individuals around the world, including staff from CADRA. This gives a consensus statement and evidence-based conclusions about the disorder that may be very helpful for you. And it was published in the Neuroscience and Biobehavioral Reviews, Volume 128, 2021.
Thank you so much, Dr. Flood. This is such a detailed answer. Dr. Vamik, I would also like to know if ADHD can be treated and what role does a psychiatrist play in this treatment?
Okay. So these are very valid questions, and these are two questions, right? So first, I'll say the psychiatrist role in managing or diagnosing ADHD. So a child and adolescent psychiatrist is basically somebody who's a medical doctor and who's trained in diagnosing ADHD, right? Through various clinical appointments, assessment, collateral information. Along with that, psychiatrists, they can be a kind of, what do you call that? A road, somebody who will develop a roadmap, right? That what are the needs of this particular child? Does this child need medication? Does this child need only, therapies? Are there other associated psychiatric illnesses? Because it's very common for children with ADHD to have intellectual disability, learning disorder, other psychiatric conditions such as anxiety or depression, that one needs to screen and continuously kind of screen them because they're more prone at a higher risk of developing such conditions. So a psychiatrist's role is just not limited to diagnosis, but also in terms of management, what is the need of the child. Overall, if we say so, ADHD, the management is available, right? And every child has their individual need. So you can't just say this is a very generic treatment for every child and every child needs medication or needs certain therapies. It depends of where the child is struggling, right? And if the child is struggling, just understanding that particular individual and seeing where the need is for their optimal functioning. Sometimes what happens is, I'll give you some examples, that children in school they're unable to sit, and because of that the class gets disrupted, so they continuously get into trouble by the teacher. So in that particular situation, there are certain things that one can do, like they can make them sit in not with their friends, maybe in front row rather than at back, or maybe somewhere where there are less distractions. But at the similar time, if the disruption is too much and because of that the child is getting into trouble, so one needs to think that are medications required or not. One of the reason of giving medication is also our system, when we talk about our educational system, especially in Pakistan, is it does not address individual needs of every child. So sometimes what happens is that children with ADHD who have inattention and hyperactivity kinds of get to be noticed every time and get punished for that. That affects their self-esteem, right? Every time it's kind of the child get labeled that if there is noise in the classroom, if somebody speaks, every teacher thinks that this is that particular child, maybe it's a female or a male, but that particular boy or girl always get punished, or and children with ADHD also have emotional regulation issues. So it's not just about inattention and hyperactivity. They have difficulty in in organizational skills, in time management, and other domains. So what happens is, they kind of, a child with ADHD, if you look at generally, if one has to correct their child 2 times, a child with ADHD will have to be corrected 15 times. And and while they're growing, they kind of sense that they can't do anything, as per the requirement of the society or that particular family or that culture. And then they kind of tend to develop, then there are 2 ways that would come out. One would be that they would internalize and become anxious and depressed and have this thing that we're not good enough. The other would be where they will become very externalizing, kind of throwing tantrums, being defiant, using bad language, or getting aggressive. So just looking at that, what is that child particular need, that's how you manage ADHD. Thank you.
Couldn't agree more on this. Managing every child's individual need is very important. Thank you, Dr. Vamik. Dr. Wong, audience would like to know the consequences of untreated ADHD.
I've seen many children, teenagers, adults, and even older adults over the last 30 plus years with ADHD. In young children, ADHD can show up as being very hyperactive, disruptive, causing problem at home, and this can be difficult for parents to deal with. And remember that children with ADHD often have parents with ADHD also. They can become very angry with what their children are doing. So this can cause a lot of family disharmony. When these children go to school, many of them have difficulty paying attention, focus on what they have to learn, and being quiet in the classroom. Not infrequently, some of these children, especially boys, can be disruptive, talking to others, and making fun in the classroom. This can cause other children to have difficulty learning in school, and as a result, many of these children get disciplined, sent out to the corridor, or sent to the principal's office. So they show up oftentimes as behavior problem in school. As a result of many of these, they have difficulty showing how smart they are. Some of them may fail even in elementary school, but more often than not, they can do quite well in elementary school and can get good marks even into middle school or high school. However, some others, their marks will start to drop in middle school or high school. There are many also still do well and get to post-secondary education like college and university. However, the demand in college and university is very different from high school. So sometimes they don't do well. They get into academic probation. They procrastinate with their assignments and projects, and they have difficulty in doing the exams. And they often do not finish college or university. As adults, it poses a different kind of problem in the sense, in other countries like Canada, they can be exposed to a lot of drugs and alcohol and use them because these drugs and alcohol help the brain to calm down, and not infrequently they become addicted to these substances. So drug addiction and getting into trouble with the law are common complications of those with ADHD. In addition, the problem that they have with ADHD lead them into anxiety because they often remember that they forgot to do things. At night, they remember that they forgot to do some of the important things that they have to do at work. And this become a problem for them. So many of them come in with stories of anxiety and depression. These can be the complications of untreated ADHD instead of true anxiety and depression. But unfortunately, many adults are treated as such because doctors don't recognize these are only the consequence of untreated ADHD. If treated, many of these people will do much better. I've heard stories of adults coming back to tell me that their treatment have changed their lives. Many of the university students have come back with marks that were much, much higher than before treatment. School-age children also come back with much better marks, and their parents were very happy with their performance. But one thing to remember is that if the parents don't get treated, sometimes it is very difficult for these children to do well. So sometimes we have to treat the whole family who have adults as well as children with ADHD.
Very true. As you said, the whole family is involved in the treatment, so it's essential for them to get family therapy as well. Thank you, Dr. Wong. We are thankful to Dr. Eugene Arnold also for being part of our panelist. Dr. Arnold is a board-certified child and adolescent psychiatrist. He is a professor emeritus of psychiatry at Ohio State University and CHADD's resident expert. He has 50 years experience in child psychiatric research, including the multi-site NIMH multimodal treatment study of children with ADHD. For his work on the MTA, he has also received the NIH Director's Award. Welcome, Dr. Arnold. It's such an honor to have you here with us today. Since we've already spoken on what ADHD and autism is, along with its signs and symptoms, I would request you to shed some light on parental stress and burnout. How common is it in parents of children with special needs?
The amount of stress and burnout for parents varies according to the severity of the child's problems. In this regard, parents of children with Autism Spectrum Disorder tends to they tend to have a more difficult time than others. And one of the phenomena that seems to occur is that the parents get kind of numb and begin to think of the child's behavior as the norm, as the way things are for all children, so that they don't realize how much stress they're under, how much they are changing their lives and scheduling their activities around the child's impairment. For example, if the youngster runs all around a restaurant when they try to eat out, they may stop eating out. They may just not go to restaurants. Similarly, if the child causes a ruckus in the store, if they throw a tantrum because they can't have something that they want the parent to buy, the parent may stop taking them to the store, which means that they have to find other means of supervising the child while they go shopping. Or they may change from shopping in a store to ordering online and having it delivered, possibly at greater expense. All these little stresses add up, and many parents either get depressed or anxious or just kind of give up and proceed through life in a zombie-like fashion. Now, if the child's behavior is less severe, if it's just a matter of, say, having to remind them 20 times to finish their homework, then they can often adjust to that. However, it's a considerable nuisance. One thing that I've noticed over the years clinically is that there seems to be a high rate of divorce among parents of children with, particularly with the autism spectrum disorder, but also with the more severe cases of ADHD, where the one parent just kind of opts out, can't take it anymore, or the parents disagree about the child's management, and relatives may be criticizing the parents. Why can't you make the child behave? So one thing that the parents need to do is to look out for their own mental health in the midst of all this, because if they are not able to function, then the child who needs extra help, extra support, will suffer as well as the parent.
Very well said. Since there are many parents listening to us, can you please suggest some practical strategies that could help them prevent burnout?
Okay, one thing is that they need some help, and this may be in the form of a grandparent or others with children with similar problems. Self-help groups and advocacy groups are a great help in this. For instance, organizations like CHADD, Children and Adults with ADD, or ADHD, or the Autism associations may provide support groups where the parents with similar problems can compare notes and also compare strategies with what they do to manage the situation and the child's behavior. One of the things that they need to do is to find some respite. There needs to be some time the parents can get away from the child and on their own, and this involves having someone else who can temporarily take over and give the parents some time off, you might say. They have a very grueling job, a very intense job, and a very necessary job, but they can't do it 24/7. They need to have some breaks. One of the things that some community organizations provide, that is the local board of mental health, or the local child care, where either someone can come into the home for a day or at least a few hours, or someone they can drop the child off at a day program, or even an overnight respite weekend. Parents should not feel guilty for doing this. A lot of parents feel a great sense of obligation. This is my problem, I should take care of it. But that's not useful either to them or to the child. It takes a village to raise a child. It certainly takes more than a village to raise a child who has severe behavioral problems, either severe ADHD or Autism Spectrum Disorder, or some other syndrome or behavioral syndrome that requires intensive parenting. The situation of a single parent is especially pressing, and some of these I think are saints. The way they manage to go ahead on their own, but they need to look for help and to accept help with it. There needs to be some system for asking for help and accessing it when it's necessary, particularly in emergencies. And some parents have resorted to calling the police for the older children, the adolescents who may get into an aggressive stage. Not all children with ADHD or autism have a problem with aggression, but it is a significant problem for a substantial number of them. And sometimes this can get to the point of being dangerous. A parent should not hesitate to ask for help in that situation from whatever quarter it might come. There are organizations that have websites with more information about what parents might do, and toolkits and other resources, not only to help parents understand what's going on with their child, but also ideas about things to do, strategies to employ. One of those is the National Resource Center for ADHD, sponsored by CHAD and the CDC. There's a joint contract to sponsor that. They have webinars, they have fact sheets, they have podcasts, and other materials, instruction videos, even things like how to deal with the legal aspects of having a child with an impairment. And that's freely accessible. There's no charge for it, and can be accessed through NRC, that's National Resource Center for ADHD, on the web. I mentioned community resources, and one thing is that other people observing the child's behavior need to understand that the parent is doing the best they can with this child, that it's not bad parenting, and that they might be supportive, at least emotionally, at least in the sense of not blaming the parent, or as happened in one case that I ran into clinically, an observer called the authorities and reported the parent for child abuse as they were trying to control a child who was tantruming. And that is, of course, counterproductive, not very helpful. The parents themselves need to learn to ignore misunderstandings by onlookers, by observers, and not feel embarrassed, to realize that anyone else who had this child would have the same difficulty, would have the same problem. Now, I also want to emphasize that this has been a kind of a negative nuance that I've taken, because I'm talking about dealing with the problems of the child, but there also are positive things that the parent needs to realize, that their youngster that can, with appropriate training and treatment, improve. And there are things the child may already be doing that are positive in between the difficult times, and they need to take some encouragement from that and focus on the positive things as much as they can. As the old saying goes, accentuate the positive, eliminate the negative. So trying to reward the times when the child is behaving well or doing good things may help to increase those positive behaviors, those good behaviors, and kind of crowd out the problems that have been manifested.
Thank you so much, Dr. Arnold. This was such an insightful information. Indeed, parents need to be motivated and guided at every step of this journey. Parental stress and burnout can be a great hindrance for the progress of the child's successful journey. The strategies you suggested just now will be definitely helpful for parents to cope up with the stress and frustration, which is a part and parcel of this experience. Dr. Dora, as you are an expert in adult ADHD, my next question to you is, I've heard that ADHD induces anxiety symptoms in adults. Is it true? If yes, then how can it be managed?
This really is a topic that needs its own discussion, but one of the comorbidities is in fact anxiety disorders. People with ADHD can often be very anxious. They have a higher than average prevalence of anxiety disorders, and this is the whole gamut. They might have generalized anxiety disorder. They might also have some aspects of a social anxiety disorder or social phobia. We know certainly in childhood that there are more commonly specific phobias that occur with people who have ADHD, and not exactly an anxiety disorder, but linked to that would be OCD, or obsessive compulsive disorder, more commonly associated with ADHD, as well as post-traumatic stress disorder. Perhaps children with ADHD are more likely to experience a trauma and perhaps also then to develop PTSD. So yes, anxiety disorders do coexist with ADHD, as does depression, and often the two are interlinked. It's difficult to say what's anxiety, what's depression. How do we manage them? Well, if the ADHD is really incapacitating, and as a result people develop a difficulty with managing their anxiety because of always being late or getting critique at work, then one might consider treating ADHD first and hoping that the anxiety symptoms will improve. However, if it's primarily in the first place an anxiety disorder, one would perhaps want to start by treating the anxiety disorder with a combination of medication and psychotherapy, perhaps cognitive behavioral therapy, as well as an SSRI, starting in a low dose. Control and contain the anxiety first before starting pharmacological treatment for ADHD. As you know, we use mainly stimulants as first choice for ADHD in adulthood, and they can increase a feeling of anxiety. So if the anxiety is not well controlled and it is a predominant issue and problem, one would need to make sure that one had first stabilized the level of anxiety by using the appropriate SSRI or other treatment. Psychoeducation is very important. So by helping people with ADHD understand their disorder, have greater knowledge of it, be less cruelly judgmental of themselves, put in place effective structures and systems to help them gain control over their lives and to feel less overwhelmed by their chaos and the stress in their heads, you can often see that in fact many anxiety symptoms associated with ADHD will diminish and go away. So this has been quite a brief overview of how ADHD manifests in adulthood, as well as anxiety. And just to reiterate that anxiety disorders are not the only comorbid disorders. There are many, both psychiatric and in fact somatic, that coexist with ADHD. But perhaps that is a topic for another day. So I hope this has been useful, and I wish you very much success and enjoyment with the rest of the conference.
Thank you, Dr. Dora. Definitely the information you provided is very useful for our audiences. I would like to end the panel discussion with this last question for Ms. Maha. What are the behavior management strategies that you use in your therapy sessions with your clients?
Autism is a lifelong condition, and thousands of studies have shown that individuals with autism can make improvements in their language and social therapies based on principles of applied behavior analysis, or ABA, are the most common and evidence-based interventions used with individuals with autism. Evidence-based means that it has consistently been shown to be effective with individuals with autism. The goal of ABA is to promote behaviors that increase growth and independence, and to decrease behaviors that are problematic or undesirable. ABA was not created to be a quick fix program, and it's definitely not a one-size-fits-all program. Although there are a range of different interventions, they generally fall into changing people's motivations or what comes before or after a behavior. The focus is on developing skills that align with their motivations and changing their environment to foster those skills. One way to promote behavior change in individuals with autism involves their motivation. Your motivation is your purpose or your reasoning behind everything you do. For example, some people may go to work so that they can be of service to humankind, and others may go to work for financial security. Individuals with autism may need more motivation to do daily tasks, and it is our responsibility as practitioners to create an environment enriched with motivation. One type of motivation involves increasing the value of something. For example, the last time I did a chore, I made it super fun by playing music in the background. You may want to make it a game with your child to see, who does it the quickest. So essentially, we want to ask ourselves how we can increase the value of the task we're teaching. For example, if I want to teach my child to ask me for things, then I may wait for my child to color her favorite Disney character and keep the markers out of reach and out of sight. Another type of motivation involves decreasing the value of something. As parents with busy schedules, we often provide free access to things our children love because it's a quick fix, right? However, we may find that over time, things our kids once loved are now being misused, or they're not being used at all. This is called satiation. And when satiation happens, it's important to consider strategies like limiting the use of the item, only providing the item at certain times of the day, or providing the item after a chore is completed. Another way to promote behavior change is by modifying what happens before the behavior. An example of an antecedent intervention for escape behaviors is pairing. Pairing involves associating yourself with your child's favorite interests and activities so that you eventually become a reinforcer. It increases the likelihood that your child will listen to you, will follow your instructions, and will want to learn and interact with you. Research with individuals with autism also shows that choice making has positive effects like decreasing problem behavior and increasing participation. Choice making gives a child a sense of empowerment because they are choosing instead of following an instruction. Choices can be provided in various contexts, including materials for working, time for working, and setting for working as well. Similarly, how we respond after a behavior helps promote behavior change as well. Positive reinforcement is when something desirable is presented as a consequence of behavior. The desired thing provided can be social specific praise. It can be preferred items like games. It can be tangible items like toys or stickers. It can even be tokens, which include points that can be exchanged for something that your child values. Positive reinforcement can be used to encourage pro-social behaviors like sharing. It can also be used to encourage daily tasks like homework or chores. Research shows that factors like the size, the quality, and the immediacy of reinforcement can all affect positive reinforcement. A common misconception is that positive reinforcement is like bribing. However, bribing is different because bribing benefits the person delivering it, and positive reinforcement actually benefits the person receiving it. About behavior change, it's very important to consider variables like motivation, antecedent, and consequence. It's also often helpful to take ABC data, which is antecedent behavior consequence data, because that collection helps us see patterns in behavior which we otherwise would not see. Having a qualified and trained board-certified behavior analyst work with your family can be very, very crucial because they can help you customize an ABA program that fits your child's needs, preferences, and your family situation. By highlighting the positive attributes of individuals with autism, we as a community can really normalize the idea that autism is so much more than a diagnosis with deficits. I think that this can also be an incredibly uplifting and empowering experience for individuals with autism. Thank you so much for watching.
Thank you, Ms. Maha, for enlightening us with such useful information. And thank you so much all the respected panelists for sharing such valuable information with us. In the end, I would like to say that it is important to treat children and adults with autism and ADHD as individuals with diverse strengths, talents, and needs. I'm sure this discussion will be helpful for you to support and value these unique individuals. Thank you.